Now we will move to the next, which is a panel discussion on what we can do in India about chronic GvHD. So we have Dr. Akanksha Chichra from Tata Hospital, Mumbai Actress Center. She is a consultant BMT physician there. So I would request Dr. Akanksha to take over and start the panel discussion and introduce us panelists. Thank you.
Thank you. Good evening, everyone. And very extensive talks by both the speakers. I will very quickly, the audience knows the speakers already. Dr. Samir Melinkri, HOD of the Hematology Department at Dinanath Mangeshkar, and Dr. Vanati, Professor, cornea expert at All India Institute of Medical Sciences, Delhi. Without wasting any time, I will share my screen and start with the questions. Is my screen visible to everyone? Sorry, is my screen visible to the
Yes,
panel?
it is.
Yeah,
It
okay.
is.
Great. Right. So we'll go one by one. I will start with the ocular GvHD first and then move on to fecal microbiota transplantation. We already, ma'am has told us that ocular GvHD, we know as transplant physicians, is one of the most common manifestations of chronic GvHD. The incidence is anywhere between 30 to 85% in patients with chronic GvHD. And very importantly, it is a very common cause of prolonged morbidity and a compromised quality of life in our patients. And as rightly pointed out, the most commonly reported symptom that we see in the transplant clinic is dry eye or keratoconjunctivitis sicca. So I'll move on to my first question to Dr. Vanati. Ma'am, what do you think would be the time point at which a patient post-transplant should be visiting an ophthalmologist?
As I mentioned earlier, I would say I would recommend you always have a pre-transplant visit as well with your ocular surface specialist, because if there is a pre-existing dry eye disease, but then that is not attributed to ocular GvHD and that gets documented. So you would know when this is worsening, which means the component of an ocular GvHD is getting added onto. And several times you would know that when, I think most of the time it's to tell your patient that when he is going to probably having an oral mucosa and a skin lesion, the eye is invariably involved here. And that's when you already prep him, and then he knows he needs to go to his ophthalmologist as soon as possible.
Yeah. So this is what is actually recommended, and this is what we have also been seeing for the longest time. Like Dr. Samir was mentioning, we also did not have a regular ophthalmologist, but we were really troubled by our patients having poor quality of life because of ocular GvHD. And from the time we started referring at the correct time to the ophthalmologist, we think that it has made a huge difference. So before transplantation is one visit should be done to the ophthalmologist anywhere between 3 to 6 months after that, and at least 3 to 6 months is what we are following. And if there is a diagnosis of chronic GvHD at any other site, most commonly like the oral, etc., then there is a very high likelihood that your patient does have at least some initial features of ocular GvHD. Dr. Shaurya, the next question is to you. In your experience, which are the commonest symptoms of ocular GvHD that you see in your practice and in your patients? And what are the predisposing factors for ocular GvHD post-transplant?
Yes, so thank you for the question. So most patients actually they complain of dry eye or maybe redness and foreign body sensation. So this is usually some of the initial complaints, and sometimes if they're not managed properly, they go on to developing cicatrizing disorder, problems of the eyes, and then that worsens the symptoms. But initially, it is primarily features of dry eye and then foreign body sensation.
Right. So, like Dr. Shaurya has said, these are the common symptoms that we see. And as you probably send your patients to an ophthalmologist for regular visits, And like we are also getting to know more and more about it through our ophthalmologist. It is not just the lacrimal gland, but the meibomian gland and other corneoconjunctival inflammation, which is commonly seen in these patients. And what about the risk factors? Any particular risk factors where you would predict that a patient would end up having a higher ocular GvHD?
So yes, so as in terms of risk factors, patients already having other organs involved by chronic GvHD, like maybe the skin, chronic oral GvHD, like in planus-like lesions, then patients with lung GvHD in our cohort of patients, and including a few patients on long-term follow-up, so maybe 5 years out, 6 years out post-transplant. These patients do develop ocular symptoms, and then we do send them to, again, as mentioned, we send them to a dedicated ocular GvHD specialist. We have the we are fortunate to have somebody like that at a hospital nearby to our center at Shankar Nethralaya, so we send patients there.
Yeah. So, I mean, most of the factors which would increase the risk of chronic GvHD of other organs also would increase the risk of ocular GvHD. So, apart from what Dr. Shaurya has already said, so use of PBSE, where we know that there is a higher risk of chronic GvHD, all the routine factors where we are expecting more GvHD to happen. And yes, very commonly, oral, skin, and eye. These GvHDs almost always do go together, hand in hand. Dr. Vanati, what are the various diagnostic criteria for ocular GvHD? And you did mention these in your talk. And which do you use in your routine practice is what I would like to know.
I think the ocular surface staining scores are the best ways to assess the amount of epithelial cell damage of the conjunctiva and the cornea. They're the most reliable indicators. The other ones, of course, which are more easy in office tests are the Schirmer's test, and you can do the OSDI questionnaires. But now recently, the Deuce 3 has revised our OSDI questionnaires. So that's one particular thing. And I think there is the ICC GvHD groups, the diagnostic criteria given by them, where they give a combination of the systemic GvHDs along with the ocular GvHDs. And that is one of the best or the most lucid ways of looking at a no ocular GvHD, a probable ocular GvHD, and a definitive ocular GvHD. I think it's a very self-explanatory table, and it's there in any article for you to go back and read there. And I think we are in the process of making or developing an investigator brochure, which we will probably sort of a classification system so that it can be ticked by the referring hematologist, where they tell us, okay, this is the systemic score of the GvHD. We had this as a part of our research when we were looking at the epidemiological prevalence of our data in our early 2 studies, which we did with Dr. Toleka and Mahapatra here. So that's a kind of a thing which always, when that score is changing, that, the person is worsening. So that's one of the objective denominators of how you would probably look at. In our center, we also have a very good dry eye suite. So we do ocular surface imaging in terms of anterior segment OCT to look at the tear meniscus height, to look at the lipid layer levels, to look at the amount of meibomian gland losses. So the ocular surface analyzer is a very good way of imaging, but you would find it's not very specific for ocular GvHD. You would find in other dry eye disease as well, the meibomian glands tend to get affected. We do not image for lacrimal glands in ocular GvHD as much as people would do for other diseases like Stevens-Johnson's major or minor here, where you would probably have a oral biopsy or something. But when it is an ongoing fibrosis, then we know that these glands are already being affected a lot.
Right. So as Dr. Vanati, clearly mentioned in her talk and even now, so there are these 3 criteria. The NIH probably to me seemed the simplest and probably is, the Schirmer's and the symptomatic. And that's probably something which as clinicians, maybe as a initial step, we can even do in our OPD before referring to the ophthalmologist. And the international consensus criteria, which, seems to be the one which is most definitive. So as far as the simple tests, when I was going through all the recommendations, again, this is what I felt, that what is possibly doable for us, like a hematologist in the clinic, is just the Schirmer's test. And what you pointed out, the patient-reported global rating of eye symptoms. I think that is something which can also help us to kind of pick up patients to send as a follow-up at the right time. So that is about the diagnosis. And what is the treatment algorithm you follow, ma'am, for your patients with dry eye, basically? Any role you think, apart from many other things which you mentioned, what about things like punctal cautery and DCT? Do they have a role now still in the current scenario? And newer agents which you had mentioned earlier?
See, I don't resort to punctal cautery in most of my patients at all, and dry eye disease, even for other pathologies of dry eye disease here. I think the crux is in understanding what causes the ocular surface inflammation here. Your tear lubrication is not going to stop the ocular inflammation. It's only going to replace the tear secretion, which is probably suboptimal. And the level of tear secretion affection depends upon the amount of, accessory lacrimal glands, the amount of meibomian glands, which all secrete components of the tear film are affected here. So it's up to the examining ophthalmologist or the ocular surface specialist to understand what is the cause for the occurring inflammation here. Is it just the tear insufficiency? Is that causing an inflammation? And that could be controlled by your immunomodulators here. And do you need the routine? Immunomodulators are used at something as 0.05 or 0.1%, which is insufficient when you have a higher quotient of immune. You might have to step it up to 1%. You might need to have a combination of immunomodulators here, besides varying the potency of the surface steroids you're using for these patients. So these involve clinical judgment, and this is where perhaps your experience steps in on knowing what would probably work best for this patient. And again, if you're abusing surface steroids, you can land up with side effects of these surface steroids, which could be glaucoma, which could be steroid-induced glaucoma, steroid-induced MELS infections. So I think it's a very cautious way of how you would combine these. These are the only things you have in your hand to manage the patients here. And copious use of lubricants, lubricant drops and ointments. And then if you need to sort of start targeted therapy, which means you're targeting the surface ACPAs which are present. Are you targeting the surface nets? Then that's going to be the highest level of treatment which is now available. Between these two, you have supplementing growth factors, platelet-rich factors, and all those which you can supplement. That's when you probably give autologous serum and all. But again, these are only supplementing. They are not taking away the inflammation. What takes away the inflammation is only your steroids. Decreases the level of inflammation is immunomodulators. And targeted therapy, you should know when targeted therapy is going to be useful for your patient.
Right, right. So, I mean, that's what I actually wanted to highlight, that it's not just the lubrication and tear preservation, and there's many other things which we do need to take care of. So, moving on to the second topic, which was fecal microbiota transplant. So, I'm not going to run through these slides too much because Dr. Samir has already covered, extensively on this. Important thing which I just wanted to touch on was that there are many things which affect our microbiome. We know that by now. And it's whether it could be transplant related, non-transplant related. And now there is so much of literature coming on about right from the time when you are birth and whether you had a vaginal or a cesarean delivery, everything and possibly anything can impact your microbiome, right? So, coming to the topic of fecal microbiota transplantation, like Dr. Samir mentioned, very important. The first step is to identify the donor, to prepare the patient for the fecal microbiota transplant. This is something which is new, so you have to counsel your patients appropriately. How do you do stool collection and preparation? That he has already mentioned in great detail, and then the final administration, which also has many ways by which we can do that. So when I was kind of making this talk, I saw this really nice timeline of FMT, and I found that there was first records of FMT in traditional Chinese medicine, and now this is where we are in 2023, where we have the FDA approval for the first orally administered fecal microbiota product. and several trials in FMT in many conditions, not just transplant and GvHD, but many others have now being linked to the gut microbiome. So starting with the questions, Dr. Sameer, what are the clinical indications of FMT and transplant, and which are the settings where you have used it for your patients?
So the indications, and the only indication where we've used it is in GI GvHD, predominant gut GvHD. And somebody who's got an associated other organ GvHD is also fine, but we haven't studied whether doing a FMT helps in the control of the other GvHD or not. Right now we've been focusing only on control of GI GvHD because, as you know, that is the most important and the most difficult one to control. So yes, so it's only that condition where we've used it.
So, and of course, the C. diff which you mentioned, and there's a paper that you have that you mentioned.
Oh yes, of course.
And like you also said, and most of us I think see this, that the patients who have a C. diff and a GvHD together, they seem to be, at least in our cohort, they seem to be benefiting the most. And there is some data now coming on just eradication of MDR organism carriage in many of the hemat patients, where it is possibly a place where it can be used. So, Dr. Shaurya, what
Let me just interrupt you a little bit over here. Sometimes when somebody post transplant comes with a watery diarrhea, the knee-jerk reaction sometimes is to just start with methylprednisolone. Without looking at the C. diff and the other organisms. So, that should be important. And sometimes when you're treating a GvHD, when you've proven that it is, on biopsy, there's GvHD, your treatment may actually have helped the GvHD, your immunosuppressive treatment. But when it slips into another infection, adenovirus or C. diff, sometimes you tend to miss it, and so you must be on the lookout. And every week or 2 weeks, you must continuously keep monitoring for these bacteria, and treat them.
That I think very rightly said. And in fact, before going to the next question, as for any transplant physician, anyone coming with diarrhea, what we do, and at every institute has probably done, is you have to screen and rule out any infection. So the C. diff, we screen for adeno, noro, all those things, biofires, which sometimes gives us answers and sometimes do not. And only then, once we are sure that there is nothing causing this diarrhea, do we consider this to be GvHD. And all patients of GvHD who are started on steroids or second line, we should be monitoring, as Dr. Sameer said, every weekly for any new onset infection. Just because your patient did not present with the C. diff or an adeno doesn't mean that they cannot get it. And CMV, colitis, adeno are known problems in patients who are on so much of immunosuppressions, and they would typically not respond very well to your FMT as well. So, Dr. Shaurya, what is the donor screening you would recommend for patients of FMT at your institute?
Yeah, so as Dr. Sameer has already pointed out, we do the donor screening for, so there are two aspects to it. One is the blood screening for transmissible infections like the viral infections, HIV, hepatitis B, syphilis, all the infections that are tested for blood donors. In addition, the stool is also tested extensively for communicable MDR. So the primary thing that we do is a stool culture for multi-drug resistant organisms. So that answers also a question in the chat box about worry about transferring antimicrobial resistance genes. So for example, in the trial that we are doing right now, we are allowing, India is endemic to, if you do a random stool culture of patients who have never visited a hospital or never received chemotherapy or anything, even patients, let's say, for example, taken up for thalassemia transplants, kids who have never been given any chemotherapy or antibiotics for extended durations, even they can harbor multi-drug resistant bugs with genes like NDM, OXA48, OXA23, and all these things. So in those situations, so that is why donor screening can lead to a lot of rejections. It's difficult to find donors who are not harboring these things. Only when we are sure that the donors do not have these MDROs, and what we are allowing is up to ampicillin resistance. So the AMPC ESBLs are the ones up to which we are allowing the donors to provide stool samples. Beyond that, anything else, VREs, other carbapenem-resistant Enterobacteriaceae, these donors are excluded. So that is one thing. Regarding the viruses, as pointed out, we also do biofires, or a focal, a limited viral screen, the Rota, Astro, Noro, Adeno, and also we do C. diff to make sure that we're not transmitting any of these bugs. Again, salmonella and all these things are also excluded. So even asymptomatic carriage of salmonella is excluded. So coming to the second question, it is difficult to get these clean, absolutely clean donors in India because of various, I would say, environmental hazards, the food that we eat, the water that we drink. In India, it is not regulated. There are no, the regulations are not adhered to. So there's a lot of indiscriminate antibiotic use in animal husbandry and also over the counter drugs, which leads to this kind of MDR colonization. Even within our patients, let's say a patient who has received chemotherapy and has been taken up for a transplant, we do surveillance cultures for patients, and we have seen the change in the microbiome over a period of serial cultures. So initially, the patient may not have had any MDRs, and then over a period of 4 or 5 months, or during the chemotherapy and then transplant, like Professor Melinkari showed, there is loss of the diversity and there is overgrowth of MDRs in the subsequent samples. So overall, it is difficult to get clean donors. That is why we usually screen at least 2 to 3 donors per patient. And the workaround is that if you get such a donor, uh, you can use the same donor for a subsequent patient's FMT as well. And the ultimate idea is to pool such good donors, like what they have done in the Heracles trial, and provide that kind of a stool bank from which subsequent patients can also be given the transplant. The other thing is that education of the donors. So what we do here is that when patients are being taken up for an allogenic transplant, maybe an allotransplant at a higher risk of developing GvHD, let's say a haplotransplant. So we try to talk to the caregivers who are the most probable donors, caregivers or immediate family members, and tell them some lifestyle modifications and diet modifications, not to take over the counter antibiotics at the drop of a hat, not to have proton pump inhibitors, simple things like that, which affect the microbiome. That can help, get eligible donors.
Yeah, right. So, Dr. Shaurya, of course, donor selection is very, very difficult for FMT in our country. But I think that is quite a good point that you have raised here, that at the time you can be proactive and be preemptive, and possibly before transplant. Now that we know that FMT more and more we are possibly going to be using, we can start screening the donors and advising them probably even before the transplant. So this was, what was from Dr. Sameer's paper, and we have also borrowed from his institute when we started doing our FMT from their department and from their ID department. And I just wanted to share our experience when we started doing FMT. So, we screened 24 donors out of, then these finally, I'll show later, 9 patients underwent FMT. And out of these 24 donors, only 8 were found to be eligible, right? So this is the kind of problem that we do face, at every institute in screening donors and getting the right donors for FMT. So Dr. Shaurya, again, just continuing with you, Dr. Sameer has already mentioned in his talk, we do not have access to the oral FMT pills in India yet. What are the other ways of FMT where it can be administered? And he, I think, showed that they do mostly colonoscopic. Do you have any preference of one over the other?
Yeah, so it's very interesting that FMT is still not considered as a drug in India. It is considered as a drug in certain countries, it is considered it is considered organ transplantation or tissue transplantation in certain countries. And when I applied for a CTRI registration for this trial, I also had to apply under the alternative tissue category when applying for the procedure, the type of procedure that we were doing. So it's since it is not yet considered as a new drug, we don't have pills and we don't have uniformity or standardization. So an FMT procedure for patient A from a donor B may be different for a different procedure from a different donor. And till the time we have, what should I say, maybe a stool bank with uniformity and the way we make pills in a proper GMP facility, till then we will not be able to have pills or commercially available pills in India. We can of course get commercially available that MAT 0013 is basically a pill formulation made by that MAT pharma company. Now what we are doing here is that we are instilling the stool suspension, the purified and the emulsified stool suspension through the upper GI route. Now that is primarily because in our experience of using the lower GI, these patients, especially the patients with grade 4, grade 3 gut GvHD, have a very rapid transit time. So when we are instilling a large bolus of, and this bolus usually comes to about 100 or 150 ml of the processed stool sample. When we instill it through the lower GI, the contact time is very less, and so the patients usually evacuated. Even after keeping in reverse Trendelenburg position and all that, it is difficult, and the patients evacuated quite fast. So we are using the upper GI route. We are instilling it in the D2, D3 segment through a nasojejunal tube, through the nasojejunal endoscopy, and then it is leading to a little bit of upper GI discomfort, lot of bloating, sometimes nausea, severe nausea. But the transit time increases and the contact time with the gut increases, and possibly the uptake of the microbiome increases.
Right. So I think there are pros and cons of each technique. We also prefer using the nasojejunal tube for all the patients till now that we have done FMT on. Dr. Sameer, a question for you. How do you manage transplant patients who are sick with steroid refractory GvHD and you're planning them for FMT? They have ongoing infections, they're on multiple antibiotics. Do you stop the antibiotics prior to FMT, and are there any recommendations for the same?
Yeah, so we do it. We would do an FMT only on a patient where we are able to stop the antibiotics for at least a short period of time. The only thing that continues is the antivirals and the antifungal prophylaxis. We don't stop that. But everything else, including Bactrim, is stopped, and at least for about 24 hours prior to the FMT. If they're sick enough to where we can't, and the ongoing sepsis, etc., we don't do the FMT. I know that Naveen in TMC, he believes that, and your experience would be that on antibiotics, you'll still do the FMT and you still find it effective, but we've not been following that practice.
I mean, in the sense, yes, of course, the recommendation is to stop. And if you just, understandably, it would make more sense to stop it and then do the FMT because the microbiome is what you're trying to preserve. But yes, in our patients who have been on IV antibiotics, if they needed it, we have not stopped it. And we have found it to be useful in that subset also.
Sure.
Right. And I think Dr. Shaurya, you kind of answered that about regulatory approvals required for FMT. Would you want to elaborate more on this?
Yeah, so as of now, it's very intriguing that CAR T cell therapy is a drug, whereas allogenic transplant isn't, or for that matter, mesenchymal stem cells aren't. So right now we are in a kind of an area where certain things are and aren't. So as of now, FMT isn't considered a drug or a regulated product in India, whereas in Europe it's a drug. In US and Canada also it's a drug. So maybe with studies coming out from here and with more regularization, eventually it will be a drug, and there'll be standardization, or maybe there'll be companies coming up with, oral pill formulation.
Yeah, right.
So
So this,
Akanksha, we actually, I went through me and the microbiology department actually went through the process of how we can prepare stool capsules, the technical procedure we had all got ready with. But then there's so much of, rigmarole involved in this, and when you have to handle all the volume of work that you do, you don't have so much of time and energy to put it into, this particular thing. So, but I hope somebody picks it up and decides to pick up. It's very difficult because I'm not sure the indications would be few. And this method that we are doing, although it's a little crude, but it's still doable, and we do see results. So I think this is difficult for anybody to pick up and start doing.
right. I
And
think
so far
it is
the
something which is definitely can be taken up as a cause because it is a simple,
yeah.
inexpensive procedure. And if it can be done as a pill, possibly, many more patients we may be
Uh,
able.
Yeah, so as
Yeah.
of now, the cost of maybe an FMT, there's a question in the chat box, cost of one FMT. It's basically the cost of the endoscopy and the stool screening and the blood screening tests. So it comes to about approximately 30,000, 35,000 for a procedure. But if it's considered as a drug, and if we have to go through the entire approval process, through all the phases of trials and then DCGN, then it'll be a huge cost. And whichever company pharma takes it up, then there'll be a huge cost associated with it.
Yeah, so that is also that side to it. I mean, I think where we spend most money is actually identifying the donors,
Yes,
because when
yes,
you have to do multiple donor workups and biofires, and these are all sometimes unrelated donors, and how do you provide funding for them because they're not really patients? So all these questions are do come across when we're actually doing the FMT. So this is our experience very quickly. In 2023, we started this. Like I said, we used the protocol with Dr. Sameer had developed at their institute. We've done it. We have done 9 FMTs for 5 different patients. We have actually added more than this now. This is the last data I have, and 6 out of 9 had complete resolution of GvHD, and 3 out of the 5 patients are surviving. So these were all bad steroid refractory patients, and FMT at that point we were adding probably once they were at least on second or third line drugs. Right. So the challenges we all know is identification of a suitable donor. And there are studies from stool banks which suggest that almost 95 to 98% of the donors screened would be unsuitable. Optimal dosing probably is something which we still have to see. Availability of ready-to-use formulations, and as Dr. Shoryo mentioned, the regulatory challenges that we have right now. And what about ethical considerations? That is one more thing. I mean, I don't know, Dr. Sameer, would you want to say something on
Uh,
this?
so we checked with our ethics committee, and they said we have no role in this. So no, it's a procedure that you're doing. You don't need ethics approval as long as the patient gives you a consent for it. We have a separate consent form. So the
Yes.
patient gives consent, it should not be a problem.
That's right. So the same thing was said by our ethics, and we take a donor consent and a patient consent, and it is now provided as a service at Actric. You can actually provide it as a service. We didn't have to go through the ethical approvals at all. Right. So, also in your trial, I think you were talking about what are the clinical and microbiological endpoints, doing microbiome analysis. So I think that is something which is important, which you're already doing in your trial for these 9 FMT patients and the few which we have done after that. We also have done the microbiome, at 3 time points. And let's see, I think when we have more data, what it is going to show us. So with that, I would like to end the panel and thank all my panelists and of course SPCTT. I think it was a good combination of FMT and Ocular GvHD. FMT being a novel treatment that we are doing, and Ocular GvHD being a very under-treated and under-recognized complication in transplant patients. Dr. Satyendra, any other questions in chat box that we have missed?
So there's one
Yes,
question. There's one question about any
yes,
role of
please.
experience in prophylactic FMT. So that is called restorative FMT, and we have done it once actually off-label, one or two occasions. But it's no. I won't say there's any data because trials are ongoing, and the best studied is by Florent Mallard. He's doing an excellent job. So you can go through some of his articles. It will come up in the future. In future.
Yeah, so I think we've
Yes.
covered most of the questions. Yeah.
Yes. Thank you, everyone. Thank you, Dr. Tulika. Thank you, Dr. Bharati. Thank you, Dr. Sameer, boss. Thank you very much. Thanks, Akanksha, Shoryo, and everyone who has attended. We decided this combo because I just wanted to highlight that these are the two aspects where a lot can be done, which we are actually not doing. And in both the situations, it doesn't cost much. It is just your conditioning and your awareness that you need it well before it is too late. So thank you very much, guys. It was really one of the best webinars, and it was the most informative. We'll meet again the last Tuesday of next month with yet another interesting topic. Thank you, everyone, and good night. Thank you.